Good afternoon and welcome to the Fall Policy Forum titled Substance Use Disorders, Charting a Path to Health Equity. My name is Brian Wimbigler. I chair the Provider Working Group for Project Hope, and we're delighted that you're here with us this afternoon. Before we get started, I'd just like to mention a few housekeeping items. Just to ensure that everyone has a lot of bandwidth and that the recording and the presentation goes smoothly, if you're not presenting or speaking, please just go ahead and mute and turn off your video to allow more bandwidth for those who are presenting and speaking and for advancing the slide deck. That'd be helpful and we'd appreciate that. Also, throughout the presentation, if you would like to ask a question, please put that in the chat box. We'll be monitoring that throughout today's activities, and we'll address those questions as they come up in the chat box to each respective speaker. And at the end, we'll also have another opportunity to go through some of those questions. So please utilize that chat function. We'll be monitoring that throughout. And without further ado, I'd like to introduce Dr. Lori Meschke. She'll be talking a little bit about the Project Hope and how this has been brought to you in the East Tennessee Consortium. So Lori, take it away.
Good afternoon, everyone. A very warm welcome to you all on this beautiful fall day. And I want to thank you not only for your interest in the presentations that you're about to see today, but also for all you are investing in attempting to address opioid use disorder in our communities. I wanted to give a little bit of a history on what the RCORP is, the Rural Communities Opioid Response Program for East Tennessee, and our consortium related to that. So Brian, next, please. Our consortium was actually initiated in 2018 with the planning grant. And since that time, we have grown into a 34 membership organization that has over 150 people on our listserv. Our goal is to eradicate opioid use disorder and all the associated consequences with it. Yeah, it's a pretty big charge. Hence, we need a lot more than 34 members in our organization. And we very much hope if you're not on our listserv or if your organization is not a member of RCORP, that you will consider joining us in this mission. We have quarterly meetings via Zoom at this time during COVID, and this being one of them. So the Policy Forum is a very special quarterly meeting. And other than that, in the next 3 months, we'll have another meeting that we hope you will attend. Next, please. The first project that we currently have in relation to RCORP-ETC is that of Project Hope. Project Hope has the important mission of reducing opioid-related overdoses, and we have been active since 2019. As Brian mentioned, we have 3 working groups. The Community Working Group, which Brian Wimbigler and his colleagues in the community co-lead, and then we also have the Provider Group that is guided by Dr. Jennifer Torville, and then I have the privilege of co-facilitating the Youth Working Group with Betsy Lowe. Together, we create trainings, resources, programming, and ideally, we are also building community capacity together. And we are also increasing the ability of the university to assist in meeting the demands, both on the research side and also in providing evidence-based community services. Next, please. In keeping up with COVID, one of the questions that we ask our members is what can we do when we cannot be out in the community at this time as we would like to be? We were told that we needed more fact sheets, we needed more tools, we needed things to disseminate to community members that maybe wouldn't happen face-to-face. So the next few slides just runs us through some of the resources that you can find on our website. Next, please. In addition to a large variety of fact sheets, you will also find that we have a youth prevention curriculum, and we are also offering that both on online and face-to-face at this time. Next, please. In addition, we did summaries as far as the resources that are available and the needs that are existing. And in order to build capacity in our communities, we are available to assist with your grant writing needs, whether that be pulling together a literature review, doing some reviewing, setting up the structure for the grant for you. We are here to make the efforts that you are active in sustainable. Next, please. Finally, we have our quarterly meetings. And again, we have our policy forum today. And may I take this time to thank our planning committee, Drs. Carol Meyer, Brian Winbigler, Jennifer Torville, Jenny Crowley, and June Jiang. With that, they have put together a really stellar program for us today. And I am looking forward to Dr. Brewer's comments in her keynote, and again, our esteemed panel who will be presenting. Next, please. The second project that we have is now Nurturing Options for Women. This is also associated with the RCORP-ETC and has the aim of reducing neonatal abstinence syndrome, or what we are now calling NOWS, neonatal opioid withdrawal syndrome. Toward this end, we are working on workforce development with the idea that we have the opportunity to enhance the capacity of our workforce and also to reduce the stigma that oftentimes accompanies some of our services and our community's attempts to assist. So with that, we are creating opportunities to provide behavioral health services, not only to women of childbearing age, but also to adolescent girls in Scott County. And then the Hill, a recovery faith-based organization in Claiborne County is working on stigma reduction efforts in their community. In addition, Brian Winbigler is also serving on this research project, and with that, he is providing a variety of trainings to enhance evidence-based practices. Next, please. So if you are interested in the RCORP-ETC, if you are interested in participating in some of the events, because they are all very community engaged in Project Now or Project Hope, please contact me or the co-director, Jennifer Torville, with the College of Nursing at the attached emails. I also very much invite you to explore our website, which is the last bullet item on this page, because the resources that we have range from anywhere from video recordings of trainings, free continuing education units, digital stories to help reduce stigma with the stories of people in our communities, and also a variety of infographics and links to community efforts. Thank you. Brian?
Thank you, Lori, for that great overview of a lot of the programs that we offer in the consortium in general. As Lori stated, a lot of this is brought to you guys and to us through support provided by HRSA. So a lot of the funding comes that way. So we are very grateful. So here's the gratitude slide. A lot of the programs in the consortium and the work that we do comes from external funding. So we're very gracious to be able to offer the services through that. So a brief look at the agenda. You already heard from Dr. Lori Meschke. Up next is our keynote speaker, Dr. Leslie Marie Buer. And Leslie Marie is an activist, a public health practitioner and research director at Positively Living Choice Health Network right here in Knoxville, Tennessee. And she's the author of the book RX Appalachia, detailing stories in treatment and survival in rural Kentucky. An expert in the field of harm reduction in medical anthropology, she holds a PhD in anthropology and a graduate certificate in gender and women's studies from the University of Kentucky, and master's degrees in anthropology and public health from the University of Colorado. A Knoxville native, Leslie Marie is passionate about the region, and in her capacity as research director at Choice Health Network, she ensures Positively Living offers practical strategies and access to quality treatment methods that meet the individualized needs of clients. Her work at Choice Health Network spans a variety of services, all rooted in providing non-judgmental care to East Tennessee's most vulnerable populations. Her work on substance use and harm reduction has appeared in the Boston Review, the Journal of Appalachian Studies, and North American Dialogue, among others. Leslie Marie is a true leader in the field, and we are delighted to have her join us this afternoon. Leslie, you're up.
Wow, that is quite the introduction. I feel a little bit embarrassed here with that nice of an introduction. So, but I'm just going to go ahead and go through what, my slide deck. And then I would love to leave room for questions at the end, because that really is my favorite part of all of this. I don't love giving monologues, but I love having discussions with people. And also when everything is over, if anyone ever wants to like grab coffee or lunch or anything, I am always up for that, because I just love talking to people, getting to know their experience and figuring out how we can all work together. Yeah, so again, I'm at Choice Health Network. Harm reduction is really where I'm placed there. And I'll talk a little bit about harm reduction in a minute. And, I'm 10 minutes from UT campus, and that's where we do most of our services. And I also have the privilege of going out to Newport. We love being in Cott County too. Yeah, just love that county and being out there, and hopefully we'll be up in Campbell County sometime soon. So we really do serve quite a large population in East Tennessee. And so I just want to talk a little bit about harm reduction so you understand where I'm coming from. I am definitely a medical anthropologist at heart and a qualitative researcher. I love hearing people's stories and then helping folks tell their story. But I'm also coming from this harm reduction lens, which certainly qualifies, I think, everything I'm about to talk about. And so harm reduction in and of itself is a social justice philosophy that's very much rooted in the late 1980s when there was increasing transmission of HIV among people who were injecting drugs at the time. And at that time, there wasn't a lot of work being done by the government to help with that, or to offer any services for folks to try to prevent transmission. And so with this, a lot of folks who are using drugs, especially a lot of folks in the LGBTQ plus community, were coming together to try to provide mutual aid to each other to prevent transmission of HIV. And how that came out at that time period was a lot of underground syringe services. So that was basically providing new syringes for folks to use, so they weren't using a syringe after someone else and possibly transmitting HIV or hepatitis C, things like that. But what's really important about harm reduction is it's built certainly by and for people who use drugs. And I think if you look in the field, it's very much valued to have leaders in the field who have experience with drug use or are currently using. So that hopefully services really are meeting people's needs, and it's not a top-down service of just throwing things at communities because that's what other people think they need. And a huge part of harm reduction is accepting people's autonomy as individuals. It's certainly very community driven, based on mutual aid, but also understanding that people are going to make decisions in their lives, and other people don't necessarily know what the best decision is, and respecting those decisions. But at the same time, if people say that they want to make a positive change, if they want to do something, being there to aid those people in doing that. And it's really is about providing as many resources as we can to folks so that they can maximize their own health. And it's a lot about empowerment. And of course, we acknowledge that a lot of harm can and does come from drug use, but we also acknowledge that much of the harm associated with drug use is actually coming from social policies around drug use. At the same time, all of us have lost folks to overdose death. I was telling a group yesterday that the number of my friends who have memorial tattoos all over their bodies is heartbreaking, right? We know people are lost, but we also realize that when people pass or when people may face negative outcomes, oftentimes that's because of specific policy decisions. And what's fun about being an anthropologist is you get to take all these classes in undergrad and graduate school that take you back to the beginning of human history. And so we know that drug use has always been with us, and we expect that it probably always will be with us. And probably most of us here use drugs in some sort of way. So whether that's alcohol or caffeine or nicotine or prescription medications. And we recognize that drug use does occur on a continuum. And it goes from complete abstinence to what I think we would probably describe as chaotic use, where it's having definite negative impact on people's lives. And there's a whole lot of in between. And of course, drug use changes through people's lives. People might use more when they're at certain stages and use less at other stages. And a main part of harm reduction is really meeting people where they're at and understanding what they say they need in order to help meet their needs. One thing that we often talk about is person first language, and there's a lot of great resources on this. If you ever need those, I'd be happy to share those. But we don't talk about addicts or drug users or things like that, because that can be very stigmatizing language, and it's also defining someone by one behavior. Whereas we prefer to talk about people who use drugs, because people are people, and then they just happen to be doing this one thing that we happen to be talking about at the moment. And it's also recognizing that people are just not one thing. And they also, yes, they might use drugs, and that may or may not be a problem in their life. And even if they do see it as a problem in their life, they might also have, 12 other things that they're dealing with. And so, this is sort of the philosophy behind harm reduction. And then when you talk about the services part of it, for us, it involves a lot of distribution of clean syringes. We take out or we take back a lot of syringes that have been used. We distribute a lot of naloxone and Narcan, which is the drug that reverses overdose deaths, which right now we have a national shortage of, which is terrifying. We also distribute a lot of safer sex supplies. We do a lot of education, and then we also learn from folks and try to pass what they've told us on to other folks. So sort of building that community through communication and education. We do a lot of HIV and Hep C testing, and then we do a lot of referral to services. And sometimes that does mean substance use treatment, but also a lot of times it means primary health care, or trying to find a dentist or behavioral health that is friendly to LGBTQ plus populations. So it's trying to refer people to all these different services that folks say they need. And that is really difficult. With our health system in the US, it's really hard to get people the services they need because most of the folks we see are uninsured. About 3/4 of the folks we see at Choice Health Network Harm Reduction don't have insurance at all. So it's very complicated to refer people to services, which is why I work on a team who is so amazing and has decades of experience of working in Tennessee, in Knoxville. And so they do a really fantastic job of listening to folks, trying to understand what they want and what they need, and trying to find the most evidence-based best services that we can get them into that they can actually afford. And sometimes that doesn't exist, which is really hard, but we're doing the best we can with those referrals. And so that's sort of what the services side of harm reduction looks like. And that's sort of where I'm coming from as I move through these next slides. Brian, if you want, thanks. And so I was asked to speak a little bit about health equity. I'm just going to go ahead and read this one, even though I hate when people read off slides, but I really love this definition from Robert Wood Johnson Foundation. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And the reason why I really like this definition is it goes outside of some things that maybe we traditionally think of as being health or health system related. And so thinking about, do people in our counties have access to good jobs that pay a living wage? And we know a lot of folks don't. Do people have quality education? And we know in a lot of places, the counties don't, because there's just simply not enough money going to the school system. We know housing is a huge issue for so many folks we see, whether that's in Knox County or Cott County, or if folks are driving in from other counties in East Tennessee. And so in thinking about health equity, it's also thinking about all these other obstacles. And if you could go to the next slide, please. And we talk about all these other obstacles, it often presents as something that sort of looks like this fence. I'm sure some of you have seen this slide before. It's incredibly popular, I know, in my MPH classes and other courses, but I think it's really useful. And so on the left-hand side, we think about reality. In our current world, what tends to happen if people are in the high end of socioeconomic status and are wealthy, they tend to keep accumulating more. And we have seen this especially after the 2008 recession and during times of COVID, where folks who were not doing well before COVID are doing worse now. Folks who were doing well before COVID are doing better now. And so that's sort of what our current reality looks like. When people talk about equality, it tends to assume that everyone needs the exact same thing. But of course, we know that's not really the case. If people are doing great, they don't need the same things that people who are maybe not doing so great do. And equity does look a little bit different. So when we talk about equity, it's about making sure that everyone has a fair opportunity. And so if you think about that Robert Wood Johnson definition of equity we just talked about, I think it almost sort of fits more into this idea of health justice, which is the far right side. And it's talking about, let's not leave the barriers completely intact and make sure everyone just has equal opportunity to overcome those barriers. What happens if we think about actually dismantling the barriers? And so as we talk about health equity and health justice and these things, I think it's just important, if you're doing research in this or saying that your organization has a mission to talk about these things, to have a clear definition of what we're trying to do. Are we just making sure everybody can overcome the barriers? And maybe that is the case in the current situation, but how in the long term are we looking at completely dismantling those barriers? And if we want to talk about, yeah, you can go on, Brian, that's fine. If we want to talk about health equity and substance use, this is definitely a semester-long course, right, that we could all take. And so I'm going to boil a few things down, and I just chose 3 sort of things that are happening in our society. And even though there's 20 more things we could talk about. And so the first I wanted to talk about, what are some of the barriers, thinking about the barriers to addressing substance use disorder, and negative consequences of substance use in our society. And one primary barrier we see over and over is classism and poverty. And that presents in many different ways. I'm just going to talk about a few ways here, but one is certainly access to healthcare and access to behavioral health and mental health care, as well as primary care and pain management. And so we have certain segments of the population who have really good access to some of the best healthcare in the world, and they use it, and that's great. But we also have other segments of the population that have almost zero access to any healthcare at all. So that means that if they are facing health issues, whether those are physical pain or mental health issues, folks are left to deal with that on their own. And oftentimes that results in self-medication, which is a rational thing to do. If you don't have access to traditional healthcare, but something is hurting, you find ways to help, cope with that pain. And then if that might lead someone into substance use, but once someone might be using chaotically, then there's also the issue of access to substance use disorder treatment. And, you go to these conferences and you hear about these wonderful treatment facilities where people can go and they have access to, medication assisted detox, and they have access to one-on-one individual treatment and group therapy, and they can go ride horses and do yoga. Like, that is so fantastic. But I would say that absolutely no one we see at our harm reduction program has access to a program like that. No one has access to that who we are seeing, because of issues of insurance and wealth. And so, poverty becomes an issue of people getting into substance use, and then also trying to stop the negative effects of that. Another big issue of that comes into this circle of poverty and classism and substance use is our criminal justice system. And so I'm not sure how well you all can see these charts, depending on how big your computer screen is, I suppose. But the US, we have the highest incarceration rate in the world, and we incarcerate the most number of people too. So we're the top in both categories. And our prison population is enormous. And even if you break this down to some of our states, so when I was doing this research in Kentucky, Kentucky would have been had the seventh largest prison population in the world if you were comparing it to different countries. So it is quite unbelievable how many people we have imprisoned in this country. And that has a lot to do with classism as well as racism, which I'll talk about in a minute. But we know that poor communities are more likely to be under investigation by the police. And a lot of this is justified through ideas around drug use and the war on drugs. And so we know that more poor people are incarcerated, do go to jail. One, because their communities are under surveillance, and two, because they don't have good access oftentimes they either have access to overburdened legal representation or poor representation. And so a lot more people end up in prison. And so that matters a few ways on the back end too, as people are coming out, which increases poverty. And so we know a lot of folks coming out often come out with felony drug charges or even misdemeanor drug charges, which often will always show up on background screens, which can prevent people from getting housing as well as jobs. And so that's increasing poverty. Also, while folks are incarcerated, they most times cannot be making any money. And if they are, it's not anything. I mean, it's not minimum wage or anything like that. It's cents on a dollar. So that increases folks' poverty. And also, while they're incarcerated, they vast majority of the time they can't be getting any education or work training. So not only does poverty get people sent to prison, but it also, prison itself makes people poor when they come out. And most of the reasons that they are sent there are because of drug charges. And just a side note, we also know that one of the highest times of people overdosing is when they're leaving prison. So we know prison increases overdose deaths as well. So this is just sort of one way in which drug use, classism, poverty, and incarceration mix to create some really bad outcomes for both individuals, families, and communities. And then I'll talk about racism, which is in the next slide. Next. And so we know the war on drugs is inherently racist. It was from the very beginning. So if we look at the initial prohibition of things like cannabis, that was done in ways that were very xenophobic and racist. And there's been some great media analyses, as well as anthropologists that have gone back and looked at the history of this. And if you see some of the propaganda that was put out for prohibition, it was very xenophobic against Mexican Americans, and it was also very racist against Black Southerners. And so it was certainly sort of part of a Jim Crow era to incarcerate or otherwise criminalize people of color. And if you fast forward to the Nixon administration, who sort of officially started the so-called war on drugs, that was also part of a very racist campaign. And so when we look at this quote from the assistant to the president for domestic affairs, I'll go ahead and read it. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate hippies with marijuana and Blacks with heroin and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. So the war on drugs was never really about protecting communities. It was actually about breaking certain communities down. And oftentimes those communities were of color and poor. And so when we think about how drug use affects people's individual lives, again, we kind of have to go back to think about this broader issue of racism in our country. And of course, when you talk about incarceration rates, those are going to be much higher for Black folks, not because people in Black communities use more drugs, but because they're more targeted by criminalization efforts. And I think that's shown on the next slide. Yeah, so if we look at, this is from 2013 from Vox, but they just did a nice graphic on it, but it is from data that is not gathered by Vox, it's gathered by the CDC and the Census Bureau. But if you look at past month illicit drug use, it is very similar between different ethnicities. But if you look at rates of incarceration, they are dramatically higher among men and women who are Black. And so, and then the incarceration rates are also higher among Latinx folks. So the drug war itself is based very much in, again, this larger construct of racism in our country, and it affects different people differently. Okay, and I think the last thing I was going to talk about right after this is, yes, stigma against people who use drugs. And so this also intersects with classism and racism to make it very difficult for people for substance use disorder to be addressed. And these are just some headlines I pulled in a few years ago from some newspapers in Appalachia, and this idea of getting clean for baby. And again, that's using this idea that if you're using, you're dirty, and everything we associate with being dirty, but if you're not using, you're clean. And just this idea of getting clean for baby. So what does it mean if you don't? It brings up all these connotations of being a bad mom, of being a bad parent, of being a bad person. And then we also see a lot of things that are used that are just not correct. So this idea of being born addicted. If you look at the DSM understanding of addiction, you literally cannot be born addicted. It is not a possibility. But it's sort of this stigma addressed towards people who use drugs, and definitely certain populations of people who use drugs, this being pregnant people. And we see this all the time, stigma against people who use drugs, and it really affects their everyday ability to get services. And this is not just about going to the doctor, which it certainly can be about. But I mean, I know people who have had really bad experience going to buy food at the grocery store, and people saying things, going into a restaurant, people saying things about people's arms, things like that. So it is just an everyday part of life of having to live with that. And especially if you live in a really small community, it can just really be brutal. And I've seen some of that acted out of discussions when I was living in small towns in Eastern Kentucky, of people coming up to people when they were at the park with their kids and saying things to them. And it's really heartbreaking to watch that. And we know on a larger level, if you look at all these, this research done in medical facilities and so forth, we know people who use drugs, if are not treated well, oftentimes in clinical settings. All of a sudden, everything becomes about their drug use, even if they went in for something that had nothing to do about their drug use. We know people who, there's certain policies at some clinics and hospitals that specifically penalize people who use drugs, which can be very damaging. And we know it causes several things. And one, it causes people to delay care. And I have talked to so many people who have said, I am never going back to such and such clinic or hospital because they treated me like a dog. You can't take me back there unless I'm unconscious, because I'll fight you every step of the way. Even if I can't walk, I'm not going back there because they treated me so badly. And we know a lot of folks, when really stigmatizing policies are implemented at places, a lot of folks will leave against medical advice, so leave AMA. So not only does it prevent people from going, but once they're there, if they're being treated so badly, they're going to leave, which is just really hard. And so, yeah. it's hard to see this happen every single day for our folks who refuse to go places. And so what I just talked about, if you want to go to the next slide, please. It's just a few of the things that are doing this, right? And all these things can intersect, right? So we know someone who's just using drugs, but maybe they're white and upper class, like, yes, they're still going to face some stigma against drug use. But where things really come into play is when people are also facing these other things like classism and racism. And then, of course, there's all these little bubbles going on the outside too. And these are just a few I named. I could probably list a few more. But one thing is certainly criminalization is such an issue. And again, we know that drug use in and of itself can at times be inherently dangerous. It can lead to overdose. But if you ask most of the people we talk to what has been a bigger issue in their lives, it is not necessarily drug use itself. It's oftentimes the criminal records they have. It's the trauma they have from being incarcerated, the trauma they have from being separated from their kids. It's all these different things that are happening because the criminalization and stigma against drug use. And so other things are going on too, right? We have stigma against pregnant people. And man, have we experienced that in Tennessee, right? So we had this law called the fetal assault law, which is a horrible name. But it already has sunset in Tennessee. But when it was active, people could be sent straight to prison. Pregnant people could be, if they were doing anything that could be considered illegal, including testing positive for drugs. And let me tell you, if you're really concerned about the health of pregnant folks and their fetuses, the last place you want to send them is to a prison. That is not helping the health, that is just criminalizing folks. So we've seen that here in Tennessee. And of course, privatization can be a huge issue when we look at the privatization of healthcare. Again, like, as I said, it's really hard to get people into treatment because it is so expensive, because so much of it is through for-profit sort of non-governmental organizations. And we just can't get people in. And furthermore, a lot of times that treatment is not necessarily evidence-based. Some of it's kind of haywire. And then I hate to talk about all the bad stuff, right? So I would like to spend the next 5-7 minutes talking about the good stuff. So if you wouldn't mind going to the next slide. Oh my gosh, I forgot about all these other bad things I talked about. I guess I'm stuck with bad things for just a few more minutes, so I'm sorry. And so what do all these things come together to affect? They affect policies, and that's what really becomes lived in people's lives. So at the federal level, of course, we have criminalization. We have things like bans on federal funding for syringes, which really hurts harm reduction programs and really limits, especially in many states, how effective they can be. And we have a ban on safer consumption spaces, which are spaces that people can go to use. It does not promote drug use. It's quite the opposite. We have at least 20 years of data from other countries showing that the only thing it does is prevent people from dying, and no one has ever died at a safer consumption space. Okay, if you can go to the next slide. All these state policies certainly affect people's lives. And so one is definitely Medicaid expansion. I worked in Kentucky when there was Medicaid expansion, and then I moved back home to Tennessee. And man, it makes such a difference in people's lives if there's Medicaid expansion, and it really does affect access to all sorts of healthcare. We have a ban on state funding for all syringes in Tennessee. In Tennessee, we have a really not Good Samaritan law. A Good Samaritan law usually protects people if they do overdose, or if they're helping someone who's overdosed. But here it only protects someone for one overdose. So you only get to overdose once and get immunity in Tennessee. Otherwise, we know that jurisdictions have been using that to prosecute people. We also have some pretty intense geographic requirements for syringe service programs that have to be 2,000 feet from a lot of different places. And so that can be really hard to place a syringe service program where people actually need it. And Yeah, just all sorts of laws that we have at the state level that further criminalize people who use drugs beyond just federal criminalization. All right, if you could go to the next one, then I'll promise I'll get to good stuff. And so we also have a lot of local policies that negatively affect our folks. As I said, a lot of the people who come see us about, a lot of people either have unstable housing or are unhoused. So when you have constant sweeps of folks constantly taking all their belongings, constantly moving them at the local level, that becomes really hard for people and can also lead to more chaotic drug use and more riskier substance use. And then we also have some local policies in city of Knoxville, for example, that limit where substance use disorder treatment programs can be, especially programs that offer buprenorphine and methadone, which are medications for opioid use disorder. And so we have some planning level policies that almost make it impossible to open up any new programs that offer MOUD or medication for opioid use disorder. And we already don't have enough treatment, and this just makes it worse at the local level. So there's all these ways that policies that are based on stigma directly affect people's individual lives. Okay, the next slide is the good stuff. Okay, here we go. As I said, Medicaid expansion is, my goodness, it changes so much. And if you look, there was all this data that came out that looked at substance use disorder indicators, both the year before Medicaid expansion in Kentucky and then the year after Medicaid expansion in Kentucky. And it really did make a world of difference. As you can see here, there was the uninsured rate for opioid-related hospitalizations, which were mostly involving overdose, that dropped to 90% in Kentucky in a span of 2 years. And in that same time span, there was a 700% increase in Medicaid beneficiaries using substance use disorder treatment. And so if you make treatment actually available, truly available, then people will use it, but it's not truly available right now. And not to toot my own horn, but harm reduction programs really are great and have, at this point, about 30 to 40 years of really good data to back up what most harm reduction programs are doing. And so, in East Tennessee, these things are kind of innovative. In other states and countries, they're not, because they've been doing it for a long time. But if we can figure out how to implement harm reduction programs in our counties, I would think that we would be having some of the same positive outcomes that other places have had. And we've already seen in our own program that we're having positive outcomes. And then, man, I love permanent supportive housing and housing first. If you look at the data, it is the right thing to do for people who are unhoused. And housing first is really about focusing on getting people in housing before any other requirements. So they don't have to fill out, stacks of paperwork. They don't have to start going to job trainings. They don't have to be abstinent. They don't have to be doing anything. You just get people in housing. And then you can start working on other issues. And there's a lot of data to back that up, that is a great model. And it's a great model for people who use drugs. And then the final thing is decriminalization, which we're seeing a lot in the last few years. And that can be, and that can look a little different. Decriminalization does not necessarily mean just everything is legal all of a sudden. There's a lot of different steps. And I saw that this week, for example, New York and Maine just took the step of decriminalizing paraphernalia, which is very helpful for harm reduction programs and for other folks. And it means sending less people to prisons where we know people aren't getting services, and it's really only making outcomes worse. And so I think there's a lot of positive things that we can do. And some of those are really little, like just being nice to people. I used to say that just like being willing to shake everyone's hands, but now COVID, and maybe we shouldn't do that. So maybe like elbow bump everybody, but just like being nice to people is such a small step that each and every person we can take. And then it goes up to larger things of supporting things like Medicaid expansion. So I think moving forward every day, there's small and big steps we can all take. And there's also a lot of organizations already doing this work. If you could go to the next slide. Yeah, so in Tennessee, or actually, let me start in Knoxville. In Knoxville, we have Black Mamas Bailout, which they're amazing, and they help get Black women out of jail, especially when people are just sitting in jail because of being on bail, and it's just, yeah, it's a really good program. And so if you go to a little bit broader level, in Tennessee, we have Healthy and Free Tennessee, and also Sister Reach, which is not up there, but they did a lot of good work fighting that fetal assault bill and really working for the rights of parents who use drugs. And then we also have these larger organizations. So National Advocates for Pregnant Women is at the national level. They do fantastic work for pregnant people who are using drugs. We also, there's the National Harm Reduction Coalition and Drug Policy Alliance, which are really working on the policy sides and showing the evidence behind harm reduction. And then there's also all these other great harm reduction programs around the country that have all these fantastic merch and also educational materials. HIPS is in DC. They have been doing this work since the early 90s, maybe late 80s. And then Harm Reduction Action Centers in Denver. That's where I was sort of trained in harm reduction, and they have a lot of great resources too. So people are doing the work. It's just hard work. And then I think the last side is just my contact info. Yep. And so if anybody has questions now, please ask. I would love to answer those. And here's my book, which I am a much better writer than I am speaker. And I also have quite a few articles out there. So I encourage you to look at that. I'm better when I have time. So yeah.
Leslie Marie, great presentation. And we've already been asked if this was being recorded and if we could post it on the website because of all the valuable information that you provided. In the space of harm reduction, it's full disclosure, I wish we didn't have to do it. I wish we didn't need these programs. I wish people like you didn't have to give of their talents to serve this population, but we do, and it's there. So for the lay person, maybe not someone that's really intimately involved, what are some just basic steps that someone can do to help with this problem and with these issues just in their own sphere of influence, not by actively, maybe working with Choice Health Networks, but in their own community? How can they start making a difference?
I think if you start just really small, like as I said, in your own community of just being nice to people. If you see folks on the street and they say something to you, maybe they're not going to hurt. Like oftentimes people aren't going to hurt you. I just be nice and smile. Like I can't emphasize about how important that is. Or if no matter where you work, I think being nice to people as they come in is really great. I think really having honest conversations with your kids or with kids in your network is really important, and not necessarily fear-driven tactics that aren't based on facts. Because I only have a 7 and 5-year-old, but man, they are so quick to call me out on anything I say that they don't think is factual. And I'm sure it only gets more intense as they'll become teenagers. And I think there's some great resources around that. And actually, Drug Policy Alliance has a whole educational curriculum you can look through and see what's right for your family. But I think having honest conversations with kids is so important, because I think that's where, you can do prevention work, but we just know that fear-based and prevention work that's not based on fear, that's actually in true or in facts, it doesn't really work too well. But I think honest discussions do work really well. And then whatever sort of community group you're part of, whether that's a faith-based organization or however else people organize themselves these days, you can always do something easy and reach out to an organization and just ask them, like, hey, we have 20 folks. Is there anything we can do for an afternoon that would be helpful? And people will let you know, people will tell you. And so I think that can be great. And also just contacting local leaders, your local politicians. we're voting in Knoxville right now for Knoxville City Council. It's really important to vote, and it's really important to tell people who represent you what you think and how we can be better, better to people.
Thank you. That's great advice. I've got 3 boys, 10, 7, and 2. So I'm right there with you in terms of when I say something that might not be exactly fact-based, and then I get, that pushback. So it's going to get a little worse before it gets better. What other questions do any of the audience members or other panelists have? Let's see, I'm watching the chat here. Okay, so there's a question here. How can I incorporate kind stigma reduction as to not offend others, but defend those with SUD and OUD? So I guess just expand a little bit more on the person first language.
Yeah, and so I put that in the next to last slide, the Harm Reduction Action Center. They actually have a really nice one-pager that talks about person first language, which I think is really helpful. And then Jennifer Torval might have to help me out here, but there was one I talked about yesterday. It's the Health and Justice Research Lab out of Northwestern that has a whole sort of fact sheets about sort of discussing sort of each statement of stigma, and I find it so incredibly helpful. So it's not just like stigma overall. It's like, hey, I heard someone that we say that we should not distribute naloxone because we should just let people die. And they have like a whole sort of paragraph and then some evidence base saying, hey, that's why that's wrong. Okay, thanks, Sam. They just put that up there, the health and justice. And then or I know they have one that's like, I heard that taking buprenorphine is just substituting one drug for another. And then it has a whole explanation of why that's not true. And so it's a really helpful resource to address stigma overall, but also to take all those little things that people say and be able to turn those things into like, well, that's not exactly what's going on here. How, like, can we talk about the facts behind that myth? So I think those are helpful resources.
Absolutely. I agree with you on reframing it, acknowledging what they say, but then reframing it in more acceptable language, more person first language. And I think the more we model that behavior, the more pervasive it's going to become within our own social groups and in society as a whole.
And it's really hard. I caught myself earlier in the presentation. We have tried to not use the word clean for anybody, anything, of course not people, but using it sometimes for needles, I catch myself. And I mean, I've been doing this a long time, and sometimes I still say that about needles. And I'm like, why did I just say that? And so it's really hard work that takes a lot of practice, and I don't want to diminish the work it takes.
We still have just a few more minutes.
I think I also saw something about data that shows the positive outcomes for harm reduction program. I have a folder of a lot of resources. If you want to email me, I would be happy to send some of that to you. Also, another great one is the National Harm Reduction Coalition. On their website, they have resources and you can look up specific things. And they have links to a lot of things. And they also have one page like white papers summarizing the literature on a lot of different issues. And so I would encourage you to look there first. And then if you need extra, I definitely have folders I can share.